Looks great.
And we're still okay. All right. So let's talk a little bit about medical marijuana. When we talk about marijuana, the difference between marijuana and medical marijuana is that medical marijuana is recommended by a physician and sold through dispensaries, but it's the same plant that is marijuana. So that we shouldn't make a big differentiation in Ohio between marijuana and medical marijuana, except for how it is recommended, distributed, and for what purpose it's supposed to be used. But basically, the medical marijuana or marijuana plant has over 400 different constituents, and the level of the different constituents can vary from plant to plant, from stem to leaf, from season to season. There are two main ingredients when we talk about marijuana: THC and CBD. THC is the psychoactive component, which gives people the euphoria, the sedation, the dizziness, the out-of-body effect that some people will get from marijuana. CBD, on the other hand, or cannabidiol, really works predominantly through immunomodulatory effects. And it really has unproven clinical effects in humans, except that we know that it can be beneficial when added into a regimen of other anticonvulsant therapies for children with some rare specific epilepsy forms, such as Dravet syndrome, tuberous sclerosis epilepsy, things along the Lennox-Gastaut syndrome. For those, it is specifically approved as an add-on therapy along with anticonvulsants. When we talk about marijuana, we tend to want to talk about the potency of marijuana. And potency of marijuana, or strength of marijuana, is based on the amount of THC in the product. And it's important to recognize that back in the 60s, when people used marijuana, THC ran about 3 to 4%. Nowadays, street marijuana may be 10 to 20% THC, and some of the products that are used as medical marijuana can be up to actually 99% if you use certain edibles that are used. The strength or potency of medical marijuana varies from one state to the next as far as what is approved or not approved. It's important to recognize that CBD does not equate with marijuana. Marijuana is 400 different constituents, THC plus CBD plus everything else. And so it is not the same as CBD, in spite of the fact that up to a third of Americans believe that CBD and marijuana are one and the same. So what are the challenges that we have to deal with when we talk about medical marijuana? First, it's important to know that medical marijuana is not an FDA-approved drug. It's not a dietary supplement. Physicians cannot prescribe medical marijuana. If you are a certified physician in the state of Ohio, you can recommend medical marijuana, but you cannot prescribe it. It's important to remember that there is essentially no quality control because, as we said before, it varies from plant to plant, season to season. So there are no dose formulations that we can go by for this product. Repeatability of dosing is not predictable. And again, there are over 400 different components, so they're going to vary dramatically. There is a lack of evidence for efficacy in most conditions for the qualifying conditions for use. And we'll talk about this a little bit later in some detail. And we'll also focus on the drug interactions that can occur with marijuana. Marijuana is not dispensed at pharmacies. It's dispensed in marijuana dispensaries which are run by non-medical workers. And these people will oftentimes give your patients misinformation. One example is a young woman comes in with nausea from morning sickness. An untrained medical person may recommend marijuana when marijuana absolutely should never be used during pregnancy. There is also a concern about cannabis use disorder, where patients really do become addicted to the use of cannabis. Roughly 9 or 10% of people who use cannabis daily will develop cannabis use disorder. And that number, particularly if people start in younger ages, such as adolescence or teen years, that number can go up to between 25 and 50% will develop cannabis use disorder. When medical marijuana was legalized, it really changed the entire paradigm by which we practice medicine. You know, we're used to, as physicians, as practitioners, we're used to FDA-approved drugs for which we know that their dose will be the same from one pill to the next, from one prescription to the next. We know that if something is approved for an indication, that it has been studied with placebo-controlled trials and have been found to be effective. This is not true with medical marijuana. It is recommended rather than prescribed. It's illegal under federal law. It is still a DEA Schedule I drug. The indications for use were not developed based on research studies or placebo-controlled trials. Rather, they're directed by the legislature. So we have what are called approved qualifying conditions, and those are debated by the legislature. There is little or no efficacy for most conditions for which these products are used. There are really only 3 conditions where there is good proof of efficacy. And again, we'll talk about that. Data on side effects and drug interactions are rather limited. This is a product that is promoted actively by the cannabis industry, by the media, and by politics. And again, I'll make the point that there is no reproducible dosing.
So what are some of the qualifying conditions that are here in Ohio? And I think most of our people are today joining us from Ohio. These are the original list of qualifying conditions. And as you can see, there's lots of different things. If you really need to recommend it, there's usually a way to do that because there are lots of interesting conditions. Most of the qualifying conditions are not based on any efficacious trials that have been completed and been successful. Sadly, this confuses a lot of people because the state legislature allows it in a certain state, doesn't make it beneficial. And I think we need to really underline that. In Ohio, you may be aware that we are currently under the proposition of adding more of the qualifying conditions. Some of those qualifying conditions may include OUD, opioid use disorder, for which there is no evidence right now that exists for any efficacious benefit of adding in marijuana to a person who already has a problem with opiates. And Nora Volkow, who is the head of the National Institute of Drug Abuse, has been quite outspoken on this topic. Many of the politicians are driving this in many states, many governors, in order to try to assist the problem of OUD. They have really been wanting to have medical marijuana as that alternative. The concern there we'll talk about shortly, but it certainly focuses on drug interactions. When a person has high doses of opiates, it is very difficult to add in medical marijuana safely. One would have to taper over time, and it's a convoluted process. Use the next slide. Here are some of the Ohio conditions for which or excuse me, the Ohio forms of use of medical marijuana. So we are not a state that allows patients or caregivers to grow. We also do not condone smoking of the product. However, inhalation through a vaporizer is allowed. And perhaps we'll have a minute to discuss that, because there are some risks associated with that. If anyone knows about e-cigarettes and electronic cigarettes and some of the aspects of that, the propellants are quite harmful and are antifreeze like ingredients. So we have concerns about that. There's also a deadly gas that we now have been able to document as being produced when cannabinoids are vaped. That is ketene, which is a deadly gas and was associated with the vitamin E acetate issues that had to do with the severe lung injury that the EVALI that we saw several years ago. So we can talk more about that if you'd like. Oils, tinctures, plant materials, edibles. Edibles, of course, you have to remember that first pass effect with the liver occurs, and that puts edibles in a category where we sometimes have to worry about not only the predictable onset, which may be delayed a couple of hours, but we also have to worry about how long the activity will go on, as people sometimes don't get what they are expecting out of the effect. They continue to eat and consequently can have a very long duration of effect. Patches, and then in any state, any other form that's approved by the Board of Pharmacy at this point. So drug interactions with marijuana, we cannot stress enough how important this is. And if we look at any cases, which we hope to do today, what we see oftentimes is that the marijuana is interacting with something. And so we have to be prepared to recognize that, prepared to change our dosing on various entities. Marijuana particularly is involved with the cytochrome P450, the 2C9, and the 3A4 varieties. That's not to say that there aren't others. In fact, the 1A2, just as with tobacco smoke, the 1A2 is an issue with marijuana as well. So what we have to do is we really do have to look at a variety of these different drug classes and how we can assist a patient. When I spoke about opiates, for example, when you put in an opiate with the marijuana, the opiates are going to increase in their ability to stay longer and have a greater activity. So that is a big concern, and we have to try to taper a person down as we add the marijuana in. And that, as you know, tapering of opiates is quite a challenge. So very important issue. With CBD, just an aside on that, with CBD in particular, there are two cytochrome P450 enzymes, the 3A4 and the 2C19. Also with CBD, one of the big issues is that liver enzymes can increase. So the AST, the ALT enzymes can increase and liver toxicity can occur. When we see CBD used, and we haven't really spoken about it, but there is a prescription product of CBD. One prescription product is available, Epidiolex. And when we see that particular product used, it's never really used by itself. It's usually used with other anticonvulsants. So one would really have to reduce significantly some of the doses of various products because so many of the anticonvulsants will interact with CBD. And this is a big challenge, especially in the little ones, who already have other issues going on. Adverse effects of marijuana. Particularly, we want to focus on the cardiovascular system. It is not unusual for people who are using long-term and high dosing to be more prone for heart attack, stroke. Tachycardia is very common. Hypotension, conjunctival injection, bronchodilation, muscle relaxant issues, and then, of course, decreased GI motility, which really can be problematic. And I want to just speak to cannabis withdrawal because it may present itself and you don't even realize. With cannabis withdrawal, we normally see that after someone has been using the product for an extended period of time, or if they are using high potency THC. And as Glenn referred to, the high potency THC is anything 10% or more is considered high potency. So street drugs of THC, most likely, as he mentioned, can be, up to 20%, up to 60%. Hashish oil and hashish, which usually, historically always was sort of the higher potency stuff, which should be about 60%. We have THC products out there that are much higher than 60%. So cannabis withdrawal can happen often. Usually we will see it after a few days or a week of cessation. And for those patients who might get hospitalized and are regular users, and they can't get the product in the hospital, it can complicate your hospitalization of those patients. So after about a week, what happens is that there are a series of different symptoms that can occur. And when 3 or more of those first 6 symptoms are seen, so if you go down irritability or aggression, nervousness, anxiety, sleeping difficulty, decreased appetite, weight loss, restlessness, depressed mood, if you have 3 of those and you have one of the items listed in number 7, that would be physical symptoms that would include abdominal pain, shakiness, tremors, sweating, fever, chills, headache, those kinds of things. You usually can categorically move towards the cannabis withdrawal as a diagnosis. This is extremely common.
So let's just talk a little bit about the evidence for efficacy with medical marijuana or cannabis. And the point that I want to make is that there are really 4 pretty much standard reviews from 4 different countries. In the United States, the National Academies of Sciences, Engineering, and Medicine in 2017 did their evaluation. It's almost 500-page book that is incredibly detailed on the use of medical marijuana. Australia has about 120-page guidance for the use of medical cannabis. In Canada, they have also, where it is legal both for recreation and for medical across the country, they have an extensive evaluation for healthcare professionals, and that was summarized in a 9-page guideline for prescribers in the Canadian Family Physicians Journal back in February 2018. All of these systematic reviews, including others from the United Kingdom and other places, all reach the same conclusions. There are 3 conditions where medical marijuana has modest efficacy: neuropathic pain, chemotherapy-induced nausea and vomiting, and subjective spasticity in multiple sclerosis. They also make the same statement that medical marijuana is not a first-line treatment for any condition. And I just want to touch on a couple of things. I want to first talk about neuropathic pain, because in virtually every journal article that talks about using medical marijuana for pain, they talk about pain in general. And if you actually look at the studies and you look at the reviews, the only place where there is pain efficacy with cannabis is in neuropathic pain. 80% of people who have chronic pain disorders don't have neuropathic pain. They have musculoskeletal pain, low back pain, fibromyalgia, arthritis. There is no efficacy. There's been a Cochrane review for fibromyalgia, found no benefits for cannabis for pain relief. Same thing for osteoarthritis. So we need to be careful that we don't just lump all pain together. It's really only neuropathic pain where there has been found to be benefit. And as far as spasticity and multiple sclerosis, that was a subjective finding. And again, objectively, there was no difference in spasticity, but subjectively, patients did feel that they had less spasticity after using marijuana. Again, it is not a first-line treatment. It should be recommended only in refractory situations where standard medical therapy has not been effective. And I think that this is probably a
Go to
good,
the next one. Okay, that's fine. Go back.
easier
Okay.
said than done. So I think this